Hello, myself Dr. Nirbhay Gupta, going to present the topic fracture healing. So now today's talk is going to be a talk about first what is fracture. First I'll talk about what is the definition of the fracture. Then we'll go and discuss this complete heading of fracture healing into three topics. One is the stages of fracture healing, difference between indirect and direct fracture healing, and factors affecting fracture healing. This this complete talk I'll going to divide into two parts. The video is going to become on YouTube on two parts. One is part 1 and part 2. Part 1 is essentially going to be discuss about what is stages of fracture, definition of the fracture, and mostly roam around indirect fracture healing. In part 2 we're going to discuss direct fracture healing, fractures affecting fracture healing, and in part 2 we're going to be talk about summary of this video, which is going to be the complete crux of this video. So first of all, talking about the fracture. What is the fracture? The fracture is a breach in the structural continuity of the bony cortex. Breach in the structural continuity of the bony cortex with degree of damage to the surrounding soft tissue. Actually, the definition of fracture is not given anywhere in a proper manner. This is the best definition which I could found. So it's a breach in the structural continuity of the bony cortex with a degree of injury to the surrounding soft tissue. Now, stages of fracture healing, there are essentially 5 stages of fracture healing, considering 0 as one of the stage. Stage 0 is where injury going to happen and there will become a collection of hematoma. Stage 1, when there inflammation going to happen. Stage 2, when soft callus, then hard callus, then remodeling. This diagram here, this complete diagram is essentially the molecular summary how the fracture heals, and this complete series is the radiological summary how the fracture heals. We're gonna discuss these two diagrams one by one later when we talk about the complete stages of fracture healing, but let's discuss each stage in detail as required. So stage 0, talking about stage 0, which is 0 to 4 hours. What happens when someone has a fracture? What you will see when someone has a fracture? There is soft tissue damage, you see. There is periosteum rupture, you see. There is bone fragments coming out, you see. There is vascular damage, you see. There is soft tissue damage again, you see. So these kind of thing which happens when someone come to us with the fracture. So this is actually the stage 0. It occurs in 0 to 4 hours when there is soft tissue damage, periosteal rupture, blood vessel rupture, and separation of the bony fragments. These are the things which happens in stage 0, which is injury and hematoma. So after that, there is going to be collection of lot of necrotic tissue. Lot of necrotic tissue will gonna collect at the fracture site. So to phagocyte this necrotic tissue, this necrotic tissue, inflammatory cells gonna come. Where once these inflammatory cells reach there, it transformed into stage 1, which is stage of inflammation. So what happens in the stage of inflammation? There is accumulation of inflammatory cells and release of cytokines. Since there is release of cytokines or inflammatory cytokines mainly, hence this stage is most painful stage. This stage is considered the most painful stage because there is lot of inflammatory cytokines which are released. So one general question, which inflammatory cell is going to be come first? Answer is neutrophil. It's the neutrophil which is going to be reached at the fracture site first. Then there are going to be other B cells. Then there are going to be T cells. In between, inflammatory cytokines gonna release. This is what essentially happens. One more important thing, there is periosteal rupture, and this periosteum has two sides. One is inner and outer. The inner gonna give the blood supply and osteoprogenitor cell to the fracture which helps in healing of the fracture rather than the osteocytes which are actually the mature cell which are actually present at the fracture site. So what happens in the stage of inflammation is the inflammatory cells which gonna come to necrose to phagocyte the necrotic debris, going to release inflammatory cytokines, and hence the stage is going to be painful. The most important the inflammatory cells is going to be reached at the fracture site is neutrophil, then other B cells, then the T cells. This is essentially what's going to happen in the stage of inflammation. So this is the stage of inflammation. It occurs from 0 to 1 day. Neutrophil are the earliest and the most active cell population remove the debris through their phagocytic mechanism. There is release of inflammatory mediators, inflammatory cytokines such as interleukin 1, interleukin 6, interleukin 8, interferon gamma, and TNF alpha. Significant pain during day 1 to 3. This is the reason why there is significant pain during day 1 to 3. It is always the progenitor cell which helps in healing of the early existing mature cell. Now these progenitor cells come from three sources. One of them I have told you that it is the inner layer of the periosteum. The other two sources which we are going to talk about when we are going to talk about stage of soft callus. Now initially after neutrophil there is granulocyte, then monocyte and hematopoietic stem cells, then lymphocytes are seen. These all are B cells. When these B cells population regresses, there is going to be accumulation of T cell at the fracture site, which I have tell you earlier. Now periosteum, as I say, it has two layers, outer layer and inner layer. Inner layer gives the periosteal progenitor cells, fibroblast, osteoblast, chondrocytes, and vascular network. Now periosteal vascular supply is important because it is this vascular supply which is going to give 1/3 of the cortical blood supply. Now after this stage, there is accumulation of chondrocyte at the fracture site. After this stage, there is accumulation of chondrocyte at the fracture site, and which going to form the stage of soft callus. So this is the stage of soft callus where you can see chondrocyte accumulate at the fracture site. Secondly, there is lot of neovascularization which happens at the fracture site. Now this neovascularization, because of this increase in blood supply at the fracture site, it flushes off all inflammatory mediators. So what happened because of inflammatory mediators, inflammatory cytokine? It was the pain which was happening in stage 1 inflammation. So since at this stage all inflammatory mediators going to be flush off, there is going to be pain relief which is going to happen. So it essentially has two things. One, lay down of the cartilage and decrease in pain. Now two questions are there. How does this cartilage lay down? What caused the accumulation of this cartilage? And how they are going to transform into bone. These are the two questions which are going to be answered in the theory of the soft callus. So first, the point which I have discussed, which flushes new blood vessel form, which flushes the inflammatory mediators, hence there is decrease in pain. Now when we talk about stage 1 inflammation, we talk that there is mesenchymal progenitor cells which come from the endosteal layer of the cortex, but it is also the peripheral blood which is another source, and there is local cell population. So there are three sources of progenitor cells: mero-endosteal cortex, peripheral blood, and local cell population that reside in the perivascular space. So these are the progenitor cells. These are the places from where the progenitor cells comes. Now soft callus, second question, how does cartilage lay down here? How does chondrocytes comes here? So it is because of two things. One is SOX9 and one is TGF beta. So what are these two? SOX9 helps in hypertrophy of the cartilage, and TGF beta helps in chondral deposition. Now how does this SOX9 get exposed and cause hypertrophy? Normally this SOX9 remains beneath the periosteum, but once fracture happened, it gets mobilized to the fracture site and it causes lay down of the cartilage. Simple. Second is TGF beta, which regulates the chondral deposition. Along with TGF beta, Hackdock signals are also there. Chondrocyte get hypertrophy and later on goes into apoptosis and form replaced by or osteoblast? So this is the second question which we are going to ask, which we were going to ask. First was answer how this cartilage deposit at the place. It is because of essentially two things, SOX9 and TGF beta. The second question was how does this cartilage going to convert into bone. So once the chondrocyte get hypertrophy, later they go into apoptosis and replaced by osteoblast. This is going to be answered in more detail in stage 3, which is of hard callus. Now collagen fiber is also present in stage of soft callus, which are rosely attached to the periosteum, which we know. Now later on, once osteoblast chondrocyte get hypertrophy convert into osteoblast, the stage of hard callus forms, which you can see here. So osteoblasts lay down the calcium and osteoid to transit from soft callus to hard callus. The osteoblasts lay down new bone formation. However, now this new bone which formed due to high catabolic activity, there is osteoclastic activity which help in remodeling. So once there is osteoblast formation, it forms a bump like thing at the fracture site. Later on, osteoclast come and remodel it. Later on, osteoclast comes and it remodels it. Now this complete from fracture, which is stage 0, to stage of inflammation, to stage of soft callus, to stage of hard callus, this complete scenario which happens, it ossifies after the formation of the cartilage. This kind of ossification is called as endochondral ossification, which means ossification occurring after the cartilage formation. There is one more ossification where there is direct injury. You give a direct contact at the fracture site and it ossifies by a different mechanism, which we are going to read in direct fracture healing. This complete scenario is indirect fracture healing. So this is endochondral ossification, where the has cartilaginous phase before getting converted into osteogenic phase, and it is seen in development of most of the long bone like femur, tibia and all. It occurs in secondary fracture healing. Secondary fracture healing signifies indirect healing and has a anabolic phase where increase in chondroblast and a catabolic phase where there increase in osteoclast and osteoblast. This is essentially the stage of remodeling. Now, the another type of ossification is membranous ossification, which does not have cartilaginous phase and skip the stage of soft callus. There is no formation of cartilage, direct formation of the bone seen in the development of flat bone, example clavicle. And in primary type of fracture healing, where you need absolute stability, primary type of fracture healing means direct fracture healing. Here healing occur by cutting cone mechanism, action basically of osteoclast, and osteoblast lay down new bone. What exactly it is, we are going to read in part 2 of the video, where we are going to talk about direct fracture healing in detail. This chart essentially could be understand when we have core understanding of the fracture fixation, how does healing occur. So when we achieve indirect fracture healing, we achieve intermittent compressive or shear stress where the endochondral ossification occur. Now if this intermittent stress converted into a constant compressive strength, then the stage of soft callus will occur. It will progress to the stage of soft callus, but stage of soft callus will not ossify because of constant compressive stress. It doesn't ossify. So when there is constant compressive stress, there is going to be formation of cartilage rather than the bone. So we need intermittent compressive or shear stress for endochondral ossification. And when we are going to give tensile stress, complete tensile stress, there will be intermembranous ossification going to happen, direct fracture healing going to happen. When there is high shear stress, the fracture site, there is more movement than desirable. There is more movement than the movement which is desirable for fracture healing. then there's going to be fibrous tissue formation rather than the bone formation. So this complete chart require understanding of the fixation or repeated learning. Then only we could able to adapt what this chart is saying. The another stage is a stage of remodeling. Osteoclast is the cell. The one thing which to remember during this stage is osteoclast is the cell which helps in remodeling of the bone. Now osteoclasts help in remodeling, providing normal shape of the bone. These cells forms the hematopoietic cell lineage are from the hematopoietic cell lineage found on the bone surface and form pits, which are called house-shaped lacunae, which could be understood from the basic histology of the bone, which we have read earlier. This activity is the reason why bone tissue heals without scarring. Now, this is a statement given by McVitie that the bone healing is different from the healing of the another soft tissue because bone heals into very of its original tissue rather than the scar. Now, the question is when remodeling is considered to be complete. It is considered to be complete when you can see the complete connectivity of medullary canal. If the medullary canal could be seen completely, this is the stage when you can see the bone has gained its original strength and has completely remodeled. So if you have put implant for fracture healing earlier, you can consider implant removal at this stage. You can consider implant removal once you can see this complete continuity of the medullary canal. Now this is the molecular summary which happens from day to day. There is hematoma and inflammation, there is soft callus, unmineralized cartilage, then there is fibrous tissue, then there is hard callus and remodeling which continue. This is a radiological summary, inflammation phase, then a soft callus, then hard callus, which you can see, and remodeling, which is continuous process. Now, types of healing, there is direct healing, there is indirect healing. Indirect healing we have talked. Direct healing we're going to talk about. Now, the basic understanding of indirect healing. The stages we have read, where it happens and what is the clinical implication of indirect healing. So it's a relative stability at the fracture site. Some micromotion occur at the fracture site, which is desirable micromotion under physiological loading. Metaphyseal diphyseal fracture, we try to achieve this kind of healing in metaphyseal diphyseal fracture and in comminuted fracture. The healing occur with callus formation, means a soft callus stage will come, then hard callus stage. Endochondral ossification or secondary bone healing kind of, which we try to achieve. There is no direct contact needed. Some gap is desirable. If it does occur, it allows some micromotion at the fracture site, and there is also accumulation of hematoma which helps in healing. Anatomical bar functional reduction. Anatomical reduction, if achieved, no problem, but it's not absolutely required in indirect fracture healing. Functional reduction is enough. If you are able to achieve functional reduction, you can achieve indirect fracture healing with adequate fixation. If you have achieved functional reduction with adequate fixation, you can achieve indirect healing. Anatomical reduction is not required for indirect healing. Absolute anatomical reduction is required for direct healing. Now, indirect healing, where it occurs in untreated patient, the one X-ray of the humerus which we see, the patient is not treated by any surgical mean, but still the bone has healed by indirect healing. Then when there is non-appropriate reduction, example, you give cast and splint or traction to the patient. Operative modes, when we operate and we try to achieve indirect healing, is intramedullary nail, bridge plating, cast and external fixator. So this is the intramedullary nail of the femur where we are trying to achieve indirect healing. This is a Jess or a K-wire kind of stuff which we have put in a boy. This is the bridge plate where we are trying to achieve the indirect healing. This is again 2 bridge plates, bicolumnar bridge plating. So what we have studied, this slide is going to be the summary. We have studied the definition of the fracture, the 5 stages. The 5 stages consist of 0, where the stage of fracture actually occur. Then stage 1, what you need to remember about the stage 1 is inflammation. Cells order, what is the order? First neutrophil, then other B cells, then T cells. This is the order, simple. And cytokines, normal interleukin 1, interleukin 6 and other inflammatory cytokines. Because of cytokines, this is painful. After that, stage 2 comes. Stage 2, there is neovascularization. Neovascularization and chondral deposition. Things to remember in chondral deposition: SOX, TGF beta, and Hector signal. After that comes stage 3, where there is conversion of chondrocyte to osteoblast. Then comes stage 4, which is remodeling. What does remodeling? Is osteoclast. Marker of remodeling is medullary canal continuity. This about the stage. Then we talk about indirect fracture healing. It occurs in relative stability, with callus formation, endochondral ossification, and has or 4 stages. This is essentially what we have read in past some minutes, and we're going to discuss the next part about direct fracture healing. And factors. Thank you.